My name is Alessia Kripa, and I work in SIVA, and I'm pleasant to welcome you at the first RCG Round. Before to introduce our speaker, let me explain briefly that we will have a Q&A question session after the round, and you can post your questions both on Q&A on BlueJeans platform and on Facebook streaming. I'm very happy to introduce you Roberto Santilli. Professor Roberto Santilli graduated from the College of Veterinary Medicine of the University of Milan, became a diplomate of the European College of Veterinary Internal Medicine, companion animals in specialty of cardiology, of course, and then between 24 and 26, he completed a master in electrophysiology and electrical stimulation at the University of Medicine of Insubria. He then obtained a PhD at the University of Turin in 2010. Roberto Santilli is the head of the cardiology departments of the Clinica Veterinaria Malpensa Nicura in Samarate, close to Varese, and of the hospital Portoni Rossi, always Anicura Group, close to Bologna. Since 2014, he has been an adjunct professor of cardiology at the Cornell University College of Veterinary Medicine, where he is actively involved in the activities of the Cardiac Electrophysiologic Laboratory. He is, of course, a co-author of the book Electrocardiography of the Dog and the Cat, now translated into 7 languages. His main research activities include the diagnosis and the treatment of arrhythmias in dogs and cats. Thanks, Roberto, to accept to speak this evening, and not only, this is only the first one of a 6 monthly appointment, and I let you the stage. Thank you very much. See you later.
Thank you, Alessia. Welcome, everybody. So this is our first RCG round. As you heard, it's going to be a series of 6 of them. Tonight, we will talk mainly about junctional rhythms and junctional tachycardia. So let's start with the clinical cases, then we can move into the RCG finding. And then again, if you have any question, any comments, anything you want to ask me, you can just write in the Q&A of the BlueJeans platform or on the Facebook page. So this is a dog, a male, 8 years old, an American Staffordshire. He has an history of cardiac murmur since birth, and he had in the last period of time 2 transient loss of consciousness, particularly after exercise. And in the last days, in the last 2 days, he had some more frequent TLOCs, so transient loss of consciousness, with weakness and anorexia. So this is the physical exam. So it was a normal dog for the body condition score. He had pale mucous membrane. He has a hypothermia. And again, the murmur was best heard on the left apical systolic area. He has a very rapid respiratory rate with a low normal for the situation heart rate. Then you have a weak femoral pulse with cold body extremities. So our plan was to do a chest X-ray and a rapid ECG and then a fast echocardiography. And as you can see from the chest X-ray, we see some cardiomegaly with some what we believe is pulmonary edema and with also venous congestion, as you can see here from both views. And this was the ECG. So let's start. So usually, as you know, we do the 12-lead ECG. We like to have all of them simultaneously. And as you can see for this dog, we suspect that this dog is in shock because he has all clinical sign characteristic of shocks, but he has a kind of low normal ventricular rate. So you can see there are QRS complex that looks normal to me. So if you look, there is a Q and an R, and is normal axis on the frontal plane. and a normal axis on the horizontal plane. Remember V1 in the first right intercostal space, and it looks normal with a tiny r and a deep S, and then you have a normal positive from V2 to V6 that are reading the left ventricle. So this is reading the right ventricle. But then what we see, we cannot see a very discrete P wave. We have something here, but we believe it's an artifact. It's a motion artifact because it's a very tiny waves and it is not repeatable. But then if you look carefully, just after the QRS complex, you can see some positive wave. They are moving. You see there is one here, then is go into it. And if you have any doubt regarding, you can go down here, and that's why we really like to do precordial, because you can see there is a positive P waves here, and then if you go up here, this is the positive one. And then you see that the P wave is going into previous QRS complex here, and you see here is even closer. So our diagnosis here is a junctional rhythm with isorhythmic atrioventricular dissociation, because the ventricle is depolarized through the His bundle, while the atria is depolarized from the sinus node. So these are sinus P wave. And so we say that is dissociated because you see the RP is variable. So P is moving into the QRS complex. This is usually due to the effect on the baroreceptor reflex, because you can imagine when you have a QRS complex with the P wave that are simultaneous, what happens is that you have an atrial contraction against closed atrioventricular valve, and this will induce a drop in the stroke volume. And that's why usually then the P wave is moving backward. But what is also interesting here, we are around 60 beat per minute. What is interesting is that also the P wave here is very slow. So it's kind of synchronized, what we call type 1 synchronization. So the P wave is moving back and forth across the QRS complex. But what is interesting here, that the P wave on the sinus rate is very low. So we have a dog with cardiogenic shock, but we have a not sinus tachycardia that is usually compensatory. We have actually sinus bradycardia together with a slow junctional rhythm. And here, let's see what happened. So suddenly, this is the junctional rate again with the rhythm, with the P sinus P wave that is moving, and then suddenly the heart rate rise a little bit. And so you can see now that there is a P and QRS complex, it looks associated. So we move from a junctional rhythm with isorhythmic AV dissociation into a sinus rhythm. But look carefully what happened when we move from here to here. And you can actually see the sinus P wave that was dissociated here, and now it comes before the QRS complex, and now is associated. And he has the same morphology of this one here. But now look what happened in the precordial. So during the junctional rhythm, we have this type of QRS complex morphology, but look what happened when it goes into a sudden change of the rate. So here we have the ventricle depolarized by the His, and the atria is depolarized randomly, but just dissociated from the ventricle. And here everything becomes associated. And look what happened. We can call it is a notch. So it's a QRS complex with a notch that is a little bit here, but it's not as visible as is in this part of the tracing. I think this is an interesting finding. We will discuss a little bit in a minute what this can be. So when we have this notch in the QRS complex, what we can consider? So myocardial conduction abnormalities that can be either due to presence of fibrosis with alteration of the conduction, or can just be aberrancies. So there is just a change in the conduction due to a change of the rate. So some minor form of intraventricular conduction abnormality is not the aberrancy that we usually think about. So due to bundle branch block, this is a type of aberrancy that is directly into the myocardium. That's why you got this type of notch. And these are all the different alteration of the QRS complex that you have to consider. So we are talking about notch. Here, for example, is here. Then we had a notch just as in our example is just after. So it's called notch R-wave. Then you have what we call splintered QRS complex with this type of morphology. You can have notch S-wave, but this is what we very rarely we can find. This is called fragmented QRS complex. And this is very unlikely that this type of complex is due to conduction disturbances or aberrancy is mainly due to severe fibrosis within the myocardium with change of the velocity of conduction. And it's important when you do ECG, you know, that you use the exact filtering, because sometimes if you use different low-pass filter, you see here, you don't see the fragmentation that you actually see here. So we like to do 150 for cat and 70 for dog. Be careful to change the low-pass filter when you want to study the QRS complex, particularly for this type of alteration. So other type of alteration of the QRS complex is also called QRS complex layering. This is due to the presence of fragmentation of the conduction. This is a type of ECG that is rarely done in veterinary medicine. So it's the high definition ECG. But look what happened in the QRS complex when you have this alteration of the conduction, not in the branches. This is an alteration of conduction within the myocardium. And as you can see here, there is a slurring. So a slowing of the down slope of the QRS complex, and it becomes more and more prolonged when this fragmentation of the conduction is present. So most of the time when you have cardiomyopathy, you don't see notch, you just see slurring, or you can see very rarely the real fragmentation that I showed you in the slide before. And there is a paper that is looking about the QRS complex duration, and they found a difference in survival. So if it's a survival, the QRS complex is more than 60, there is a half time of survival. And then there is another paper about the notch on the QRS complex, just like ours. Usually this is fixed, but in our case, it was just due to the aberrancy related to the sudden change in the rate and the presence of normal AV conduction after a slow junctional rhythm. And they found that the purple is when it's present a lot, usually with systolic dysfunction, because there is a lot of fibrosis. And if you say yes or no, obviously if there is cardiac disease. So when you see a notch, it's always a sign, an ECG sign that you have alteration of fibrosis. So you can find mainly the slurring, but in severe fibrosis, you can find notch, or even better if you find the fragmentation. And be careful not to confound the notch with the presence of J-wave. So J-wave, remember, is the early repolarization. So it's just at the end of the phase 0 of the action potential. You have the tiny in dogs, very commonly you find this type of positive wave that is called J-wave. And if you use the right filtering, usually you can see it. In a normal situation, you don't. And this is a paper that showed that a lot of breeds can have J-wave. And you see most of the breeds can have J-wave. And this is a completely normal finding for dogs. This is the splintered QRS complex, usually has been associated with alteration of the intraventricular septum, particularly associated, as you see from this very, very old paper, with the presence of tricuspid valve dysplasia. And finally, remember the fragmented narrow QRS complex or the fragmented wide QRS complex. And this is what we see. You see, you must see more than one change. For example, this is a fragmentation of the S wave, but you see there is a lot of spike. And this is not very common. Well, when you find it, this is particularly important because it's a sign of severe fibrosis of the myocardium. So why we have fragmentation? So it's a type of conduction in the myocardium with a lot of scars. Scar due to fibrosis, inflammation, fibrofatty for RVC, and so on. And so when you see a fragmentation, this is usually a sign of underlying cardiomyopathy. This is also true for notch R wave, or also for the presence of different cardiomyopathy when you also have fragmentation, notch, or slurring. So let's go back to our case. So you see there is a severe mitral valve dysplasia, severe left atrial dilation, severe left ventricular dilation. And again, this dog with really, really hypoxia, and that's probably that's induced the cardiogenic shock. This is the mitral valve. You see there is short chordotendine, presence of regurgitation. And there is a very, very high filling pressure with the presence of mitral valve regurgitation, as you can see here. So our diagnosis, mitral valve dysplasia with left ventricular, atrioventricular remodeling due to volume overload, acute alveolar pulmonary edema with cardiogenic shock, and what we consider the presence of acquired sinus node dysfunction together with this junctional escape rhythm that we saw. And so we use furosemide, pimobendan, and then this is in CRI, as you can see here, to solve the pulmonary edema, and then we start dobutamine, try to balance the presence of bradycardia, hypoxia, and the presence of cardiogenic shock. At admission and 12 post treatment, as you can see, there is a major resolution of the pulmonary edema, and the dog was actually better. And see here on the DV view. This is pre and post. As you can see, the contractility, obviously the volume looks better, but obviously because there is also an increase in the rate, and also the contractility, the increase due to the use of dobutamine. At admission, again, very, very high filling pressure, and this is just after treatment, they were a little bit decreased. This is the 3D of the mitral valve dysplasia, so with all the leaflet that present alteration of the structure. So let's go back to our ECG again. We had this ECG with junctional rhythm and the presence of bradycardia with isorhythmic atrioventricular dissociation. And this is 12-hour post. Look what happened here now. The rate gets better. The P wave, you see, you have a bifid P wave. So also in the atria, there is a change in the conduction. Despite the use of dobutamine, the atria is really remodeled. And so there is a slow conduction that induces an increase in the activation time. But look what happened after a longer pause. Here now you have a normal looking P wave. So how this can be? So we never think that when the atrial activation during tachycardia, most of the time in disease heart, go along the posterior left atrial wall. And that's where you have non-uniform anisotropic conduction. That's probably why you have this type of P wave. And then suddenly, when the rate gets longer and slower, it goes anteriorly. So the area of the left atrium anteriorly is more rapid in the conduction. So this can be an option, and you can actually see quite well here the bifid P wave here, posterior activation of the atria, particularly of the left atrium, slow induce this low activation. That's why you got the left atrium here. And then it's much better, so you don't see the left atrial activation when it's going, the activation of the atria with a slower rate going anteriorly, so where it's faster. And this is what usually happens when you have the activation of the atria. So the interatrial conduction over the posterior connection is very, very slow. And that's why you have this type of activation. But sometimes when you have also the Bachmann bundle block, it can actually become negative in the last part, because the activation at the end starts from left and go back to right. But this is very, very rare, either in human, and I haven't seen yet a case in dog. But here, after the longer pause, the P wave gets better again because there is a conduction along the anterior left atrial wall. So then what we did, so we discharged the dog, and we used a torsemide, imobendan, enalapril, and spironolactone. The dog was already on enalapril. Otherwise, as you know, we can use combination of drugs and also other ACE inhibitors, just like benazepril. I mean, there is no major difference. So let's talk now a little bit about these arrhythmias. So usually the AV node is charging the dog from 40 to 60. This is, and usually below 60, we call it escape junctional rhythm. From 60 to 100, roughly, we call it junctional rhythm. And if it's more than 100, and usually less than 180, we call it junctional tachycardia. So let's move now and try to understand why this dog had this junctional escape rhythm so slow. So usually the sinus node respond quite actually very, very bad to progressive hypoxia. And this is due to an effect, direct effect of hypoxia on the sinus node. And so for some patients, it's not common, but we found, just like this case, we also found other patients that present cardio deceleration when they have desaturation. And there is also some idea about the amount of desaturation needed. So the likely mechanism to explain this unique phenomenon is the effect of the hypoxia on the sinus node. And so there is a real electrophysiological effect on the sinus node. So there is a slowing directly due to hypoxia. And usually this is for human, probably it's going to be the same for dog. Below 80 to 90, we see this acquired sinus node dysfunction due to the effect of hypoxia. As you saw, as soon as we treat the animal and we solve the edema, we obtain a control of the junctional rhythm and also of the sinus bradycardia. This is another example of an obstructive bronchopneumopathy in a cat. As you know, junctional rhythm are very, very rare in cats. I have also sinus node dysfunction is very, very rare, or also maybe absent in cats. And so if you look at this particular trace here, we see some P waves and a QRS complex with a change in the axis. So there is a left shift, minus 30, from 20 to 30. There is a tiny Q wave in AVL. This is the change in the first vector because there is a left anterior fascicular block. So usually what you have to see is not just the presence of S wave in 2, 3 and AVF, but the presence of Q wave in AVL, because this is the first vector that changed direction. Is now the vector coming from left to right, activating the septum when you have a simultaneous activation of the two left fascicle. But here you have just an activation from the posterior fascicle because the anterior is blocked, and this change, so there is a superior to inferior activation that produce a Q in AVL. And you see when this cat has a severe hypoxic problem, what happened? You have again this acquired and just intermittent bradycardia with a junctional escape. Be careful, because here, if you see this type of activation, and here looks that the QRS complex is changing, but it's not the QRS complex. This is the P overimposed on this negative, so the sinus P that is dissociated. Just like our dogs, also in this escape rhythm, we have a junctional escape rhythm with isorhythmic atrioventricular dissociation. You can see the P that is moving back and forth across the QRS complex. And this is, again, another example of hypoxic-induced bradycardia with junctional rhythm, here and here. So let's move now to another case where you can have junctional rhythm. And I also took some ECG that some of you posted on our canine and feline arrhythmia study group. So we know that sick sinus syndrome is when you have sinus node dysfunction with symptoms, so with syncope and T-lock and so on. And obviously the most common is ion channel dysfunction, but you can also have some infiltrative form. There are cases also with cardiomyopathy, and then there is fibrosis of the AV node. But since it's a familiar disease, particularly in Westie and miniature schnauzer, also in dog, there should be some ion channel dysfunction. But remember, you also have extrinsic factor inducing it. And so you have some dysautonomia, some vagal inappropriate vagal reflex, so vasovagal syncope. And again, we also have hypothermia, hypoxia, obstructive sleep apnea. We got a bunch of cases. We are preparing a case series about that. And particularly, you probably have read the paper about Cavalier King Charles Spaniel, that they usually have alteration of the nose inducing this obstructive sleep apnea. So this kind of acquire is due to extrinsic factor. And then you have, in most of the cases, sinus arrest with or without junctional escape. So it's very common to have it. So let's see a particular case of sinus node dysfunction. As you can see here, there is a very long sinus pause, up to 9 seconds. So the idea is that you see there is negative P wave, P prime wave, so we call it P prime, and then another P prime is here, and then it's a sudden stop with a junctional escape here. So let's look what happened before the sinus pause and after the sinus pause. So look what happened here. We have a negative P prime, negative in inferior lead, more positive in AVR compared to AVL. So it is not concentric. To be concentric, so starting from the junction, AVR and AVL should be exactly the same. So this is not the case. And so it's probably arising from the area of the coronary sinus, since we have a flat lead 1. So remember, lead 1 tell us if it's right or left. If it's left, it's negative in lead 1. If it's right, it's either like here flat or isodiphasic. So this is a very commonly, there is an escape rhythm starting from the area of the coronary sinus ostium. And you know, we will discuss in a minute, this is an area where you have still the AV junction, but it's an area with a very, very slow conduction. And that's why you have a long PQ long PQ with a form of Wenckebach, because then you have a shorter PQ, and then suddenly there is a longer pause. So there is no sinus P wave, so it's a kind of sinus standstill with this escape coming from the junction, particularly the area of the right posterior right atrium. And then suddenly you have, after the pause, there is this junctional beat, and we will now look into this area here. Then you have a sinus, and then again the escape from the coronary sinus area or the posterior junctional area. So let's look this particular beat, and we can compare with this sinus beat. Be careful here. You see that the ST is flat here. If you go here, you see there is a negative here. So it's negative in 2, 3, and AVF, and equally positive in AVR and AVL. So it's coming exactly from the middle of the heart, from the anterior junction, and so the axis is here, 5, between minus 80 and minus 100. AVR and AVL are exactly the same amplitude and the same polarity. And here is the video showing you that it's coming from the junctional. When I say the anterior junctional is concentric, AVR and AVL equal, and then all the inferior lead negative. If it's eccentric from the coronary sinus that is here, usually AVR and AVL are not exactly the same. And this is the anatomy of this area. So the coronary sinus is where we have this low pathway. Remember that also in dog, just like in human, there is a dual longitudinal dissociation of the AV node. So there is an anterior conduction, very, very fast. It's the fast pathway along the foraminal valley and the interatrial septum, and then there is a slow pathway down here close to the coronary sinus. So in this dog, the area is when you have the escape from the coronary sinus from the right posterior junctional area. And then suddenly when we got the junctional beat with the retroconduction was here, so was from the area of the fast pathway, there was a retroconduction back in the atria. And be careful also in this other example of sinus node dysfunction, you have a P and QRS complex T, this is a sinus. Then you have a junctional rhythm. Look now nicely, you can see the presence of the sinus, the presence of this junction, and here, tiny negative P prime wave in the ST segment. And if you look, are negative in inferior lead, 2, 3, and AVF, equally positive in AVR and AVL. This is a concentric retroactivation, and so is from the junction, so he's activated the ventricle, and simultaneously is going backwards along not so fast, because you see the distance between the QRS complex and the P prime is a little bit long, but the P has a concentric retroactivation. That means that it's still going along the fast pathway, so anteriorly along the interatrial septum. And it's a kind of long RP prime. And then here, there is another example where you see, if you compare very well here, you can see that there is a junctional escape, and these are the T wave, and then you see into the QRS complex, there is this tiny negative P prime wave, again with a kind of long RP prime, but still concentric, because AVR and AVL are equally positive. But what is important, lead 1 should be almost flat. Here are some example of our colleague from Korea, and he posted on our group of Facebook group. This is sinus. Then suddenly you see there is a junctional escape, and you see now there is In this beat, you can see a isorhythmic atrioventricular dissociation because the sinus P wave is moving back and forth across the Cures complex. But what is very interesting, if you compare with the sinus here, you see that at the end of the Cures complex, you have a pseudo S wave. So this is a P prime. This is the best P prime because this is anterior along the fast pathway. And when it's along the real fast pathway, the RP prime is very short. That's why we call it pseudo S wave. You see it's negative in inferior lead and equally positive in AVR and AVL and flat in lead 1. So short RP prime, this is a classical feature for a retrograde conduction along the in the His using the fast pathway going along very rapid along the interatrial septum. And this is the other example. We have just 3 leads for this one, but still this is sinus. You can see there is a very nice J wave. This is don't consider this a notch, it's just the J wave, it's a normal. But then compare this ST with this. You see, there is a negative P prime in the ST segment, a very, very positive here, and a flat here. So it's not a concentric retroactivation. So probably this is just, again, a junctional with a sinus that is moving dissociated, or can be some form of retroactivation arising from an area close to the posterior right atrium. And also look at this one here. So this is a nice sinus rhythm. The axis is deviated toward the right. As you can see, AVR is the more positive. There is the first and the second vector here in V1 that is reading the right ventricle, and then you have all the negative from V2 to V6 that is reading the left ventricle. So this is a complete right bundle branch block. And suddenly you have a long pause, and here you have a tiny P, negative in inferior lead, flat in 1, equally positive in AVR and AVL. So this is an example again of a junctional escape beat. In this case, the P is associated and is retroconductive. And is different from, after the sinus pause, it's different from after what happened after the second sinus pause. Look at this Cures complex. This is very wide, so our first differential that is ventricular. But then what happened is you look at the morphology is exactly the same. It's just wider, but the morphology is exactly of the beat conducted with the right bundle branch block. So remember that you can have different effect of the rate on the bundle. So here you got some complete right bundle branch block, but after a long pause, we have what we call phase 4 aberrancy or bradycardia dependent aberrancy. And so the Cures complex is still a right bundle branch block, more block because it's after a long pause due to the aberrancy. Remember, aberrancy is not just on a normal Cures complex, can also be on bundle branch block Cures complex, also on ventricular ectopy complex. So this is a phase 4 or bradycardia dependent aberrance. So let's finish with junctional tachycardia. And remember, during sinus rhythm, you have the sinus, the atria are depolarized from the sinus node, and then through the AV junction, there is the ventricle. When you have junctional tachycardia, they start here. And so the ventricle is activated usually from the junction. That can be either be the atrial junction or the His. That we will see there is the 2 different types. And then the sinus node can be silent, so you have retroactivation, or can work, and so you have isorhythmic AV dissociation. So these are the 2 tachycardia that we published. So the non-paroxysmal junctional tachycardia and the focal junctional tachycardia. So this is another ECG that I posted for you, and we discussed it a little bit on Facebook. I want to discuss again with you here. So this is the non-paroxysmal junctional tachycardia. Look how nice you can see there is a very prolonged P, and also is bifid. When you have prolonged and bifid, this is the posterior right atrium. Again, exactly as when you have a positive and bifid is the posterior left atrium, or this is the posterior right atrium. So close to the coronary sinus where you have a lot of non-uniform anisotropic conduction, you are very close to the His. So the PQ is short. And be careful, because when I posted, I asked you, do you think this is pre-excitation? So you can read erroneously, because it looks that you have a positive wave here. But remember, when you have a very prolonged P prime arising from the posterior right atrium close to the coronary sinus, so the floor of the right atrium, you have a big T sub A. So this, what you see is the T sub A going on top of the QRS complex. So you have a negative arising from the coronary sinus, short PQ, normal QRS complex. So this is arising from the posterior right atrium. And look carefully here, zoom, bifid, prolong. What happened here, and now we will do a zoom about this. So you have negative and Y, negative and Y, negative and Y, and suddenly you see here you have an area of P prime that's still coming, in this case, from the anterior area, because you see it's concentric retroactivation. AVR and AVL are equally the same. The axis from minus 80 and minus 100. And if we zoom this, let's see this one first. You see, this is the P prime here. This is the posterior AV junction, close, remember, to the coronary sinus ostium, P prime, T sub A. So be careful not to be confounded that this is a delta wave. The P prime is 88 milliseconds. This is a very, very common feature for conduction along the posterior right atrium when it's negative in lead 2, or the posterior left atrium when it's positive in lead 2. And then you have a P prime Q interval 102. If we look at this one, this is the P prime, and this is the anterior area, because now the P prime is 53 milliseconds, so it's faster. And if we measure the PQ, it's actually shorter. So be careful when you measure PQ, be careful, because this is the anterior area, so the PQ is faster, but the activation of the atria when it starts anteriorly is faster, when it starts posteriorly is lower. And here you have the comparison between the posterior and the anterior. And this is the same for all junctional rhythm. If the P is usually negative, or is, as you can, in a minute, it can be sinus and dissociated. And we already saw it. So the difference is the PQ shorter and the P prime shorter. So this is how you can do the differentials. So what changed? There are two ectopic foci that are firing, and the difference is related to the prolongation of the conduction in the right posterior atrium. It's not the AV junction, it's the atria that change. And then when it's activated anteriorly, just like here, you see at this point that the PQ gets faster, because also you have a faster activation along the fast pathway. And again, fast pathway anteriorly, interatrial septum. Slow pathway posteriorly, close to the coronary sinus ostium. Here you have prolonged bifid P wave. Here you have short and fast P prime wave. Remember, somebody asked me, why is not a wandering pacemaker? Actually, it was a very good point, because we got some sudden change in the P prime from positive to negative. But with wandering pacemaker, what happened is a change of the P according to the respiration most of the time, or but at least a change in the heart rate. So faster, superior exit close to the cranial vena cava, and so you got spiky P wave because the vector of activation is parallel to lead 2. When it's coming from the inferior, so close to the caudal vena cava, this is high vagal tone. The P are actually, you see, less tall because are perpendicular to lead 2. But when you have, and this is the classical sinus node wandering pacemaker, then you have the sinus node to the AV junction, but also in this case, you still have change of the P. It's not a sudden change. It's getting slower, change the P, and then shift to a negative. Here, nice from the anterior and the fast pathway. Look how spiky is the P. It's not coming from the posterior right atrium, where it's very prolonged and slow. Then the last one is focal junctional tachycardia. We know that we discussed a lot in our group. So we published back in 2012 the isorhythmic AV dissociation in Labrador Retriever. So you have this type of junctional rhythm where then suddenly the sinus P wave is coming back and forth. So isorhythmic AV dissociation, the atria are activated by the sinus P wave. The QRS complex is coming from the junctions, from the his. And so the sinus P wave and the QRS complex are dissociated with a similar rate. And this is called synchronization type 1 because it's moving back and forth according to the baroreceptor reflex. And then we have synchronization type 2 when the P is also called accrochage, when the P is always before the QRS complex. Remember, and we will discuss in a second, is the P that is actually pulling the QRS complex at the same rate. So there is a synchronization type 2 because it's the sinus node that is actually increasing the rate of the junction and it's getting very close. But if you move along, you see some wear, you see some change in the PQ interval. You see that this P is a little bit more into the QRS complex. So be careful not to confound this with pre-excitation because you have the Q wave, so there is no possibility in a dog with a normal septal activation that you have a pre-excitation, and also because the P is still dissociated but synchronized type 2. And here the zoom, you see that this P is a bit more left-sided, this a little bit more right-sided, is going into the QRS complex. So isorhythmic AV dissociation with synchronization type 2. So the synchronization between atrial and ventricle depend on different factors, electrical and mechanical. What is important, and again, I told you that the sinus node has this boost up effect on the nodal pacemaker cell. So it's actually pulling and increasing the rate, trying to get it at the same rate. Then, in the synchronization type 1, the baroreceptor reflex changed the position of the P, but in synchronization type 2, there is this boost up effect. The synchronization remain constant and when the rate do not differ more than 10% from the average heart rate. When it's more, then you start having synchronization type 1. So this is another example here where you have what happened during focal junctional tachycardia. When the sinus rate drop, you have what we call focal junctional tachycardia with one-to-one VA retroconduction. And if we zoom here, you see this P prime here, just like in a pseudo S-wave, equally positive in AVR and AVL, negative in 2, 3, and AVF, and flat in 1. So this is going backwards. So the His is activating the ventricle and simultaneously is going backwards to the atria along the fast pathway. Tiny p, concentric retroactivation because AVR and AVL are equal and with the same amplitude. And the axis is between -80 and -100. So focal junctional tachycardia with 1-to-1 VA, ventriculoatria, concentric retroactivation. All right, so this was our first ECG round. I invite you for our second one, so just schedule it if you like, if you enjoyed the first one. This is gonna be the 1st of July at the same 7 p.m. Italy time. And we will talk a little bit more on atrial fibrillation, new insights. So we will talk on all different atrial fibrillation. We'll talk how differentiate long-standing from non-long-standing, vagal atrial fibrillation, and so on. So, and then starting from the third one, if you have a particularly interesting topic that we want to discuss with us, you can just write on our Facebook page or on my Instagram, and we can prepare some. Maybe I will put a poll on Instagram so you can decide the round 3, what topic you want to discuss with us. These are my contacts, so most of you know, the one that you are not already registered on our canine and feline arrhythmia study group. Now we are almost 800 cardiologists, and it's a very active group, and we are discussing ECG, and a lot of colleagues are doing very, very nice diagnosis. And then if you are not yet registered to my Instagram page, I suggest to do it, because here we do also some online education. We do live journal club where we have our new paper coming out. So if you want to stay updated, you can register on our Instagram page. Thank you very much for your attention. And now I'm happy to entertain any question.
Okay, thanks a lot, Roberto. If you can have a look on the backstage chat, I post for you a question came from Facebook. So I think that the colleague from Taiwan referred to the 12 hours track that you show for the clinical case. Ask, can we call AVF fragmented?
Okay, so when you have at least 3 waves on the R wave or on the S wave, yes. But if there is just a change like this, so you got RSR, this is more a kind of, can be more considered notch R wave or notch S wave. So to be considered fragmented, the oscillation should be on the same wave.
Okay, and always the same colleague say that missed the part when P will be in front of QRS and when after for junction rhythm.
Okay, so the P, when it's positive and is moving back and forth across the QRS complex, or is just before the QRS complex, so you have to consider that there is the presence of isorhythmic atrioventricular dissociation. This is usually sinus P wave. When it's negative in the inferior lead and is before or after, you have to decide if it's coming from the anterior or the fast pathway, or the posterior or the slow pathway. In such a case, so if it's anterior, the P wave is usually short in duration, and with a concentric axis, so AVR and AVL are equally in amplitude. If it's coming from the posterior right atrium, then it's bifid, very prolonged, and usually if it's before the PQ, it's shorter. But the P prime is very, very long. And if it's after the QRS complex, usually the RP prime is longer. And for if it's coming from the posterior right atrium, and the RP prime is shorter if it's coming from the anterior right atrium.
Okay, perfect. Another question is, how can we distinguish a junctional escape beat originating from the floor of the right atrium or from the floor of left atrium? Sorry.
Okay. I apologize that I saw that it's from Korea. It is actually from Taiwan. Sorry for that. Yeah, I should have remembered. And okay, yeah, it's a good question because you can have escape from also the posterior left atrium. And in both cases, the P prime is prolonged and bifid, and it's negative in 2, 3, and ABF. So again, what will tell you right or left is lead 1. So if lead 1 is flat or positive or biphasic, usually this is coming from the right floor of the right atrium. If lead 1 is negative, it's coming from the floor of the left atrium.
Okay. Again, Hang is asking, do we still see A wave in transmitral flow spectral Doppler with junctional rhythm?
Absolutely, yes. And it depends on the position, obviously. If it's very, very close to the either before or after, usually you have some fusion between A and E. But if it's, sorry, E and A. But if it's on top of the QRS complex, you cannot see it. But most of the time, either if it's coming from the right posterior or from the right anterior, it's usually visible, and you can see the difference between E and A.
Okay, perfect. Other two questions. The first is non-paroxysmal junctional tachycardia common feature of digitalis toxicity in dog and cat?
This is a good point. Has been shown for humans, yes. I have not the same experience for cat. Most of the cases that we see is the one that I show you in this presentation. So either dog with sinus node dysfunction or dog with hypoxic sinus node dysfunction, just like the case that I presented here, or you can just have junctional tachycardia. So for junctional tachycardia, there are some particular breeds, like Labrador in particular, that are very, very commonly affected. From junctional, most of the cases are sinus node dysfunction, either acquired or due to intrinsic or extrinsic factor. But I cannot remember a particular case related to digitalis. Can happen, but I don't think it's considered the most common cause.
Okay, perfect. In the Q&A session, there is just a question on the AM stuff with the exercise intolerance and mitral valve dysplasia that you showed at the beginning. Thomas is not sure to understand well if you said 8 years or 8 months old. Was the dog?
Was actually 8 years, and the mitral valve dysplasia in some dog can remain silent for a while. And most of the time, there is cases where, particularly in bull terrier dogs, you can actually have some mitral valve dysplasia that stay for a long time with no symptoms, and then suddenly they come with pulmonary edema. And usually it's a severe pulmonary edema. That's why it's really hypoxic, because it's usually, this is another important comment, usually in mitral valve disease, due to degeneration of, myxomatous degeneration, is a chronic onset. So there are a lot of compensatory factor working. For this dog, it's more acute onset, and that's why they become severely epoxy very, very suddenly.
Okay, perfect. And always Thomas is asking if with this diagnosis, with proper medication, what is the life length on the expectation, the life expectation, I think.
Sorry, can you say it again? I miss you for a few words.
Yes, always referred to the same cases. that you show with the ANSTAF, with this type of diagnosis and with an appropriate medication, what is the life length or
I
expectation?
think since they remain a lot of year, most of the cases has some year without clinical sign, and then suddenly they decompensate. Usually when we see them, they are very, very advanced disease. And so that's probably why this as soon as you start treating this animal is a very late disease, and they don't have a very, very long survival. So I would rather say less than 1 year.
Okay, Roberto, if you agree, we have the last question from Annette.
Okay.
What treatment would you give for congestive heart failure mitral valve disease when they are refractory to furosemide? I think that is very, very interesting to answer it.
Okay, as you know, particularly in advanced congestive heart disease, we like to use what we consider for mitral valve, obviously for acquired mitral valve disease, we consider class D. We really like to shift from furosemide to torsemide. And we have several cases now long-term treated with torsemide. And in most of the cases in class D is used either once a day, but better twice a day. But now we are also in class C, we are using torsemide with a once a day treatment. And also in these cases, you can control long term without major alteration of the kidney function. So, and if it's not enough, in class D, then we increase pimobendan, we use amlodipine, but there is a period where when you reach the amount of furosemide, if you are using this in class C, and then you move to class D, and then you have to shift to torsemide. Most of the time it works for long term. And obviously, spironolactone now, as you know, is recommended for class D already. So for class D, I didn't say that we add it, but in case this dog is not getting spironolactone, we usually add spironolactone at this point.
Okay, if you have time, there is just a question on the association of denazepam and spironolactone. I don't know if Thomas or which class is referred to, but is asking if you prefer to use in combination or separately for better titration. Benazepam and spironolactone.
As you know now, as I already said, there is already in class C now, there is the use of ACE inhibitor together with spironolactone, so we use that. And obviously the combo drug can be used because there is for the owner there is less drug to use separately. And I mean, most people sometimes have the idea that we should use also benazepril twice a day, and I mean, some people say yes, some people say that you can just use once. But in combo, we like to use together, and I don't see any, major difference if you use together other than use separate. So we like to use also together.
Okay, Roberto, thank you very much. I think we solved all the questions, but if some attendees, as you told, as some other, can write on the group, on the Facebook page. And I would remember again that we will have the second events, the second ECG round on the July 1st at the same time. And you have the registration link, or you can follow on the Facebook page as you did this evening. Thanks a lot, Roberto.
Thank you.
See you the next time. And thanks everybody, and my colleague from SIVA from participation. Bye-bye.
Bye-bye. Bye-bye.